Number two, the hospitals, very few of them may be really very pain conscious. Not all of them are. Maybe it's yet. They might become in future, I'm quite sure about that. So hence, any anesthesiologists here who are going ahead with epidural, kindly go ahead with epidural until you master these techniques. That is just that I wanted to underline, and I was thinking that I must say it before I started with last. Thank you, sir. Well, actually, action potential is miraculous. Have a look at it. Could you give me the audio, please?
Once initiated, the action potential travels unchanged all the way from the axon hillock to the axon terminals.
It's the essence to understand toxicity,
responsible for this all or none propagation of the action potential occur along its membrane. Here, in a cross-section of the axon membrane, we see the movement of sodium ions, shown as yellow spheres, into the cell as the action potential travels down the axon. As the action potential moves along the axon, brief changes in voltage across the membrane cause sodium channels, which are embedded in the axon, to open. Positive charged sodium ions then move from the outside to the inside of the cell. The positive sodium ions move inside the cell because they are attracted by its negative charge. After the action potential passes, the sodium channels close.
That was what action potential was all about. But remember, there are sodium channels even in heart. So the nerve, the local anesthetic is going to act on action potential here. It's going to act on the action potentials in the cardiac tissue as well. And it has its own complications because of that. There were certain very important years in local anesthetics: 1905, Procaine; 1932, Tetracaine; 1947, the Independence Day of India and introduction of lidocaine; 1955, chlorprocaine; 1957, 1963, the latest; 1999, levobupivacaine. So these were all in the pursuit of getting a safer local anesthetic. So from the injection syringe to the local, to the actual site, that is the sodium channel, what happens to the local anesthetics once we anesthesiologist inject it? It follows the rule of mass movement and takes up the path of least resistance, which unfortunately need not always be the nerve that we intended to block, and hence the necessity to be as close to the nerve as we could. Secondly, it then starts diffusing. Third, it gets absorbed, and that is where probably the toxicity begins. And then the target nerve membrane, so the sodium channel. So once the, could you shoot the video? Once the local anesthetic indeed comes in contact with the nerve membrane, this is the channel opening, the drug molecule gets into, it comes in the acidic milieu of the exoplasm, gets itself attached to the H ion here, which yes, here it is, and then goes and blocks the action potential. So that's how our local anesthetic work. So now coming down to last, how does this get extended into systemic toxicity? Well, what are the manifestations of it? It could be in two ways. One is the cardiac toxicity and the CNS. The less sinister, in fact, is CNS, so we'll deal with it first. Progressions and signs are as follows: vertigo, tinnitus, ominous feelings, circumoral numbness, granulousness, tremors, myoclonic jerks, convulsions, and CNS depression. If you're an adult anesthesiologist, well, you're lucky, you're going to see all this. If you're a pediatric anesthesiologist, fine, you have missed all this because your child is either general anesthetized with a muscle relaxant or sedated. So you yet have a chance if the child is sedated. There was a good review article which looked really into the mechanism of cardiac toxicity. Well, this is a play of the local anesthetic and the sodium channel. So what does it do? It binds the cardiac sodium channel during the systole and dissociates during the diastole. The rate of dissociation of bupivacaine from the cardiac sodium channel is much slower than lignocaine. So the time of dissociation is not adequate for bupivacaine at our physiological heart rate, and it's not enough for its complete dissociation. Hence, this particular drug is so cardiac toxic. Is there one common mechanism for LA-induced cardiac deaths? Not really, there are many. Arrhythmias, left ventricular depression, resuscitation, drug failure. Mechanism so depends on that specific drug. There is this professor here. Could you just pack it up a little, because I don't want them to see the entire arrhythmias. I'm more interested in showing you what probably might happen with lignocaine. He is a very passionate teacher and is trying to tell you the atrial contractions with his hand and the ventricle contractions with his legs. So that's how it begins. So that's the atrial contraction, that's the ventricle contraction, the atria, the ventricle, the PVC, fibrillation. It's chaos. He's shutting down. He is personified heart. We come along, we try to resuscitate it. If it's not bupivacaine and in a whole big dose, he comes up again, the atria, the ventricle, the atria, the ventricle, the atria, the ventricle. Fine. Good resuscitation. So probably that was not bupivacaine. Now again, he goes along, the atria starts, the ventricle begin, the PVC, okay, fine, fine, fine. Yes, the heart goes in a trichy here with all possible arrhythmias that can it ever experience. Now we come along, we do our best, given up. Probably that's bupivacaine. In infants and children, this is seen too, but it's masked by a concomitant GA. Inhaled anesthetics may raise threshold for seizures and delay detection of toxicity. Progression of events are even more very rapid. Allergies to LA, yes, but not too very common. Coming down to the treatment of last, the very basis of this talk. Why are we discussing all this? We need to prevent it first because it's always more safer. Prevention of last, we will go stepwise. How do we inject? How much do we use? Are intravascular markers indeed useful in prevention of last? Which modality we use in prevention of last, whether ultrasound or PNS or both? Let's look into this. This is a beautiful paper which all of us should read. These are guidelines written. How do we inject? We aspirate no matter what technique we use. So aspiration is a must, whether it is needle or a catheter. False negative aspirations are 2%, but it's a very simple technique which we all have been drilled into. How much to inject? Use incremental injections of local anesthetics. Inject them in aliquots of 2 to 3 cc's. Hold on for a while and then go ahead again. Issues with fixed needle approaches, such as, say, peripheral nerve stimulation, like once you get an appropriate motor response, your hands are supposed to hold the needle right in the position where you elicited the response, perhaps not even breathe, and give your local anesthetic by repeated aliquots, repeated aspirations, so the needle doesn't move from the point that it was at. Well, so since the needle hasn't moved and it is by any chance in the vascular compartment keeps on receiving the drug. Hence, it's a good policy to wait for at least some time, say 30 to 45 seconds, because that is one arm brain circuit time. If you're putting the block in a lower extremity, maybe wait for a little longer. So 30 seconds is not a big deal. With ultrasound, if those who are practicing would know that you hold the probe in one hand and you keep on changing your needle. Sometimes you go posterior, sometimes you go anterior to the nerve. If it's in the interscalene plexus, you go to C5, then you go in between. I mean, you keep on changing your needle, and hence the local anesthetics are given in aliquots and placed in aliquots in the body too. So probably it is a safer way. How do we inject? Prevention of intravascular injections is perhaps best accomplished by combination of USGRA and epinephrine. Use of how much to use? Maybe we should use the lowest possible dose that gives us the optimum clinical result. Are intravascular markers useful? Yes, they are, although not very perfect. Epinephrine is the most common marker used. Epinephrine of more than 10 micrograms per ml in adults increase the heart rate by 10 beats per minute and systolic blood pressure by 10 to 15 millimeters of Hg. Epinephrine as a marker in children, intravascular injection of epinephrine 0.5 microgram per kg in children produces an increase in blood pressure of 15 mm Hg in systolic blood pressure. Coming down to the treatment as such, airway management, nobody needs to be told under this roof about this, circulatory support, and we are going to now harp upon intralipids as well. Prevention of airway like hypoxia, primacy. I mean, why is this so important? It's important because it holds on to the milieu in a manner that resuscitation is easier. It halts the progress to severe collapse, seizures, and facilitates resuscitation. So immediately oxygenation and ventilation has to be conducted. How do we control the seizures? Benzodiazepines, it's always available with us. Small dose of thiopentone or propofol. Refractory seizures, we always have the good old dexamethasone or any other muscle relaxant in very small doses. They are recommended for persistent seizures. Treatment of cardiac arrest, advanced cardiac life support with following modifications are recommended by the guidelines today. If epinephrine is used, small initial dose, that is 10 to 100 microgram bolus in an adult. Vasopressin is not recommended. Avoid calcium channel blockers and alpha-adrenergic receptor blockers. If ventricular arrhythmias develop, amiodarone is preferred. Treatment with local anesthetic is not recommended for treatment of local anesthetic toxicity, that goes without saying. Coming down to lipid emulsion therapy. 3 questions need to be asked: when, how much, and why. Lipid emulsion therapy need to be commenced at the very first sign of last, after, of course, the airway management. How much should it be given? Bolus 1.5 ml per kg, 20% lipid emulsion is what is recommended today. This is how it works, or this is how the scene is today, thanks to the rats.
The animal initially has a rapid heart rate and strong developed blood pressure. Upon an intravenous bolus of bupivacaine, the heart rapidly stops beating. We then begin chest compressions to attempt to resuscitate the animal.
Yes.
Concurrently, we begin an intravenous infusion of a lipid emulsion. After just 1 minute, the heart begins beating independently with chest compressions to help distribute the lipid emulsion. After 2 minutes, the beating continues to improve. Within minutes of lipid emulsion treatment, rapid heart rate and high developed pressure is observed, indicating a strong return to independent beating and circulation.
So that's how lipid emulsion work. Well, now having given the bolus, we need not leave it alone. It has to be topped up with an infusion, which is 0.25 ml per kg per minute of infusion for 10 minutes after circulatory stability is attained. In circulatory stability is not attained, in that case, reconsider a rebolus 0.5 ml per kg per minute. After that, rebolus needs to be instituted. Approximately 10 ml per kg lipid emulsion for 30 minutes is recommended as upper limit of the initial dosing. Does it help in children? Well, it remains speculative as usual. There is just one case report, 3 ml per kg stat bolus has been used. Lipid therapy, why? Because it acts like a sink. It pulls out the bupivacaine that is sitting in the heart on its sodium channel. Should we stock intralipid? Of course we should. This is Holy Family, the center that I work in. I have and be emphatic about what you want to the sisters. They do listen, and if it's for patient's benefit, nobody says no to it. And it's a very, very simple thing to have. Propofol is not a substitute for local anesthetic, which we are so tempted to believe. Failure to respond to lipid emulsion, well, there is one good way out of it. Cardiopulmonary bypass, it bridges the time until the LA dose actually wears off. Notify the closest facility capable of providing this in case that particular setting doesn't have it. So steps after the resuscitation, observe the patient at least for 12 hours. In conclusion, last can be prevented, last can be treated. Do not perform a regional block without resuscitation backup and 20% lipid solution, and remain a regional enthusiast. It's a nice way of giving anesthesia. Thanks a ton.